A very good morning to all of you and welcome to JIPMA. I welcome all the delegates both from India as well as from outside to this meeting. And without further ado, I'd like to introduce our first speaker for today, who will also formally welcome the gathering, Dr. T.S. Ravi Kumar. Dr. T.S. Ravi Kumar is the director of JIPMA.
Not the least alumni from abroad who are here. And I will not be able to mention each of the names, so I welcome you all to this scientific session. So all of you, especially the guests who are here, you've come through this gate already. That is really welcoming to all of us. So as Venkatesh said, every day approximately 30,000, if not more, pass through this gate, including patients, their relatives, some others, family members, and faculty, students, probably more. So this gate gets through a minimum of 30,000, if not more, every day passing through, and most of them during the first half of the day. Patients walk in without appointment. So we are truly vertically and horizontally integrated health system. Every day, currently about 6,200 patients walk in or come through in the two-wheelers or four-wheelers or through ambulances. And in addition to the 6,200, about between 4 to 600 come to the emergency room. And so our outpatient department is full, and we will see a little bit of a smattering of it in the afternoon in the movie we are going to show. So in my talk, we would like to showcase only about the high-end programs this morning in the interest of time. One of the important things that any health system needs to emphasize, and the imperative is that in India, the quality, transparency, reporting, and patient safety has not been well emphasized. So I found this when I came here as one of the sine qua non of this institution like this, where we need to take it up to be the national leader. So that is going to be the 10 minutes of my talk, just to give you an overview of what we have done in the last year and a half for quality and patient safety. And we would like to use some uniqueness as we want to proselytize on behalf of JIPMA to be the JIPMA model. So what are those components, for example? So this should be a leadership committed, but cannot be from top down. It has to be grassroots driven. So that we have already implemented in terms of my commitment on leadership. I'll show you an example. And also how we galvanize the grassroots level. Only then such things will sustain in a culture. And as a leader, and the group providing the leadership, we would set the tone and set the priorities. How did we do that? So how did we set the priorities and set the tone? When you go to the web page, rarely you will see that in the web page, under the CEO's message, you will see the button for quality and safety. So I have not seen this in many, maybe I've seen once, if not none, where the quality and safety is emphasized right in the landing page. So that is symbolic of the importance we want to give for patient safety and quality. You can navigate immediately through quality and safety. And in order to provide the tone and the trajectory, I myself take it on, has taken it on as a director of quality and patient safety until I pass it on to the next leader, which should happen sometime very soon. So both by setting the tone and making it, emphasizing it, we show that this is a very important priority. And second is, we create a vision. What is the JQC? We call that JIPMA Quality Council. I'll come to it in a second. We need to, the goal is to develop the science of patient safety again in Indian context and make JIPMA a national leader in healthcare quality. There are some underpinnings and some evidences already in the ministry that we are in dialogue with, which I will come to in the end of my talk. And in order to do this, and while we are doing this, we transform ourselves into an HRO, the high reliability organization. That's what the reliability, every time we do this at the right time, the right patient, every time. So that is a reliability science that built into the quality. And then we function as a quality leader. We have assistant leaders, the coordinator and the member secretary. We have the committee that implements it. And I'll show you how we do the grassroots in the organizational structure of the JQC. The second and third part of my credos are they engage the diaspora and we need to motivate the young. So they are the future. The young, the faculty, the students, the young staff are the future of this institution. Once you get them convinced and get them into the position, and they will be able to sustain in the decades to come. Otherwise, it will be top-down driven. It will go away when I leave or some other senior professors leave. So we engage the diaspora. How did we do that? How did we motivate the young? So when we started this, after my 6 months here, in October, in keeping with the Patient Safety Awareness Week, we organized a CME on patient safety, and we made quality counselors out of each department. So we have 70 members. There are 70 departments. There are not only academic departments, the departments such as engineering, sanitation, civil, electrical, and so lab services. So what we do is create members from nursing, from allied health sciences, so from all types of departments, from administration, from finance, so to be members. So everyone takes this message to their own department, and they become part of what we decide and design as a quality cell. So this is one of the uniqueness that we have, which even though I worked for 12 years in quality, I have not seen this in the systems that I work. There's usually a quality cell, there are quality managers, the quality nurses, they come and audit the charts, and then every department who is now brought in to show them what their quality metrics are. So here they come and they participate and they develop the science of patient safety for JIPMER, which would want to be a model for the public sector for the rest of the country. And all these people, when we engage them, these are all the people I went to the departments and I told them, don't send me the senior professors, send us the intermediate or the junior faculty or the staff, so that they will be the one who is going to be participating, and they will be the one who are going to be ensconced in this for the future. So they are all young faculty members or young staff, and some senior professors are also there. And the next principle in this is emphasize the principles, but do not give them in a cookie cutter. So what I did in North Shore LIJ or Geisinger system or Einstein or Robert Wood or Yale or Harvard where I've been, don't use the same principles, same techniques, or same decision trees or methodologies that we use here, but emphasize the principle. That's what we did in the workshop and what we did in the education cell. And then they will have to work as groups to find solutions based on evidence that is existing in the literature, and then put it in the JIPMER culture where it can be sustained in the Indian scenario. So in order to do this, what we had was to get everyone together and say, so what are the important areas that is important in the Indian context in JIPMER, where we can design solutions for defined domains. So we created JKC domains and assigned those 70 counselors into multiple groups, and we came up with all these 12 important areas. Never events group, medication safety group, sentinel event group, workplace workforce safety group, checklist and communication group, fire and disaster management group, radiation safety group, and accreditation is a byproduct. We didn't form a group for accreditation, which is going to happen incidentally as a byproduct. Nosocomial infection, hospital-acquired infection, important. Blood injection safety, operational and interventional area safety, lastly, emergency services redesign. Since then, we have added 2 or 3 more groups for fall prevention, safe mother bundle for GYN OB, and lab services service line. So all these patient safety counselors, JIPMER quality counselors, will organize themselves into small groups, and they work on each of the areas and bring it back. So then what we did the next year, for the last October, a year later, we included 100 new counselors into this group, second cohort. So the first cohort, people who have already been converts into quality, are now named champions. The new people who are coming in will be counselors. So we role-define the champions and the counselors. So the first year was spent on designing the processes and some baseline information and get the outcomes as a next step. So the champions now will be responsible in each of the departments to measure, develop the KPI, key performance indicators, and look at the measure the outcomes, while the counselors, new councils will do what the JIPMER quality counselors did in the first year, take it to the department, try to implement things in a process-driven mode. And next is, important thing in any of these things we do is when you set something up, don't stick with that. If it doesn't work, find the barriers and redesign in an iterative fashion. So this iterative fashion happens at rapid cycle interval, which I'll show you in the next slide. And then we need to celebrate our accomplishments. So how did we do that? So JQC, the rapid cycle learning model, happens on a monthly cycle. So that every month there's going to be group level learning, intra-group brainstorming, to identify the problems and pilot studies, and then evidence-informed best practice guidelines. And then they will take it and experiment. It's not 100% yet, but it's what we are striving to do. At the department level, the quality counselors and then patient safety champions will implement across all those 14 domains into their own departments, what they learned. And then bring it back into the group level learning on a monthly basis. So we have monthly meetings, which I chair, which is I mentioned everyone, those through 3 hours is taking my Valium. All the stress of being a director administrative thing, I relax and enjoy all these people coming and presenting what they found, what they didn't learn, what they should learn. And this is going to be my best part of my month, where I sit in these meetings, learn from all these departments, all these domains. Now it's going to be doubly pleasurable. Now we have to have a larger classroom to accommodate these 170 people. So these are all our quality champions and quality counselors. So they come together, intra-group learning, at the quality council meeting every month. They spread this across the 14 groups, and then each of the quality counselors and champions take all this learned from 14 domains into their own departments, experiment what is applicable, what not applicable, and then bring it back to the next month meeting. So it is almost like a 2-month cycle, where we did one this month, we go and experiment the next month and come back the third month to see what works and what didn't, and then we do an iterative cycle almost every quarter. So this has to happen on an iterative fashion. In so doing, what happens here is this communication gets amplified. So everyone knows what's happening in the rest of the other departments, what is applicable, if not, and they're connecting themselves to the department and then back into the quality council. So now we're going to do some more. We're going to add a few more nurses who will do the charter audits, and we have other service line things we're going to set up. So we are already in the process now to develop key performance indicators. And then I'm going to show you some accomplishments. And another thing we have to do is adopt a culture. I'll show an example of what my associate Muruganandam said, but we have several things, what we do for local culture, acculturation at the local level. So to use an example, maybe Rajiv will know because he can link from here to the University of Michigan, is when we communicate, we want to make sure the communication doesn't get garbled to the person who's receiving the communication. It's the S-bar principle we use in the US. We add the I because you need to identify yourself. So this is in order to everyone to remember, we call this is-bar. That means this time in Hindi, it's called this time. Har bar means every time. So we're going to say that har bar is bar. That means people, when they start to take on the phone or mention something, they remember is bar. So that means har bar. That has to happen every day. So this kind of things, we'll do this across all these areas to get into the local culture and how to sustain this kind of a messaging in the medical community. So one major thing I want to share is what do we accomplish? Even though we have to find some outcomes in each of them, which I will share, is JIPMER was never in the past. It was recognized as a medical school, as a top 5, 7, 3, whichever polling you look. And as a research, in terms of publications, we are close to 9 or 10 in the national level. In terms of grant funding, we're below the number 10. We want to get into the top 5. But as a hospital, because there's always a safety net hospital, they're all poor patients. There's so much volume. We have not placed emphasis in the quality. So as the best multi-specialty hospital among the 16,000 hospitals in India, JIPMER was never ranked as one of the best multi-specialty hospitals. So as a coincidence or as a byproduct of what we did for quality and the message spreads, this is the first time in history, in last November, in this one of the major pollings, JIPMER was ranked number 6 among the 16,000 multi-specialty hospitals in the country. And this is across both corporate as well as the private sector hospitals. And so this is a real accolade for us. Among the public sector hospitals, obviously, we are jealous of the number 1 and 2, All India Institute in New Delhi, and in Chandigarh, they're number 3. As I was telling my University of Michigan colleagues, we may be number 3rd, but when you look at the value we deliver, the funding inversely proportional to the square of how we are away from Delhi. So our funding in terms of our budget is abysmally small compared to All India Institute and PGMR. So I'm going to say that if you give me funding, like you did for AIIMS or Chandigarh, we'll be number 1. So we are getting about 20-25% of the funding while producing 60-70% of these institutions do. So having said that, this is a lighter vein, but in real terms, I think we are in good company and we want to be emulating PGMR and Chandigarh. But then I sent this to the ministry saying that the ministry should be proud that INIs band together as a top 3 institution in the country in terms of best multi-specialty hospitals, so that they will be convinced that money is well spent in these INIs. And another part of how we want to import in the landing page of JIPMER, when you go here in the landing page, you have an events reporting system. Our events reporting group designed an anonymous reporting right in the web page, and now we want to emphasize people to work in a blame-free environment to report all the errors. That is the thing, the culturation that we need to happen. So we made this happen again, emphasize the importance of quality, importance of reporting. And our nosocomial infection group, the HAI, hospital-acquired infections, is a very important thing. They put this pocket guide and they do the messaging. They have a reporting system form that we have developed. And our WHO checklist group is emphasizing it in all operating rooms, in sensitization, teaching them. And the second phase is for documentation. And radiation safety group conducted radiation safety, and they are making a best model in the country. And the fall prevention group is working on all the falls, and the safe mother bundle is to improve maternal outcomes. And as part of the Never Events group, they looked at bed sores, stage 3 and 4 bed sores as a snapshot. The Never Events group looked at the bed sores, the whole of JIPMER, and to find solutions for unstageable bed sores. We found there are at any given time that are 15 Never Events happening at JIPMER among these 2,200 beds, which should not happen. So this is the kind of approach we are taking in terms of attacking it at all levels. And prescription analysis. Our medication safety group is working at multiple departments. We're looking at ICUs and outpatient departments first. And there are people who are working on this, MD thesis on this. And the major findings are that prescription errors happen a whole lot more than what we can imagine. And that is brought to the attention of the faculty and the students in the diaspora, how these errors can happen in terms of transcription, translation, and writing, illegibility, and all that. As part of the workforce safety group, we make sure that we want to be hepatitis B friendly. We call it B friendly. Everyone should be immunized against hepatitis B, which is abysmally low in the Indian system. So that is one of the outcomes. And we are starting to work on the culture of doing root cause analysis for any major sentinel event or any major error that happens resulting in harm to the patient. We are in the process of teaching all the faculty, and this becomes one of the gospels of how we do the root cause analysis, and this will be a work in progress. The other initiative, the multiple initiatives for another Never Event where the missing babies or babies that are swapped, we have tags that we develop, reporting forms, safety checklists for safe injections, and we redesigned the emergency room for triaging and for resuscitation driven by this JQC. And we have made, the goal is to make about 500, if not more, patient information forms for the patient are informed in local language of what procedure they're going to have and what are the expectations they should be. So as a result of the first year, we did in the public domain, in the public institution, is the first time an institution has put together a manual on patient safety, which is homegrown, developed in the system, and to be adopted, and the ministry is taking it into consideration for adopting it into other public sector hospitals in the country, and we want to keep giving the message, the same thing like I mentioned in the beginning, right care, right patient, right team, right place, right time, and do it every time. And we have started with advocacy to the Ministry of Health and Family Welfare. I had a very brief but very good in-depth meeting with the current health minister during my visit 10 days ago. That I proposed 3 things for the ministry to take on at the national level. One is never events reporting. And these kind of reporting doesn't happen in India. So we need to be able to have transparency and make sure it's not blaming the hospital, but make sure we identify these never events, make sure they enable the hospitals to prevent never events from happening, which will drive the quality of the care in every hospital. And second is hospital-acquired infection. Even for us, it's a big problem. We show them our tactics. And then we need to compare the hospital performance. There is no risk-adjusted hospital mortality in India. So we propose these 3 things for the ministry to take on. So in order to make it palatable, I proposed to the minister that we propose 7 never events. There are 29 never events in the US and similar numbers, almost similar numbers in UK and Australia. So we said, consider this Series 7. Call it a Series 7. It should be Series 7. And then use this across several areas. Wrong patient surgery, patient falls with deaths or disability, suicide in health facility, mismatched blood transfusion with deaths and disability, retained objects in surgery, maternal death in low-risk pregnancy, and injury from metallic objects in MRI. It happens even in JIPMER. When I came here in the year, we had a metallic object resulting in serious harm to the patient in MRI. So these are things across radiology, surgery, medications, criminal justice system that should be taken on in India. Is our proposal. And we are, for HAI, we use the 10 tactics. JIPMER is implementing these 10 tactics from reducing inappropriate device usage, drug usage, all the way to partnerships and antimicrobial stewardship. Otherwise, India is facing a big problem in the resistant bugs in the healthcare system. And lastly, have grit. When my counselors get disillusioned, they don't get receptivity in their department, or my champions are saying they're not getting the data, I told them culture change doesn't happen in 1 year or 2 years. So in a word, I said grit means sustained focus. That's the word. In the world over, organizations that better performers are distinguished from organizations not so better performers by one criterion. Organizations that have the grit, that have the sustained focus on the goal, all be the best performers, and those who do not keep on changing that are not going to be the laggards. So I keep encouraging my champions and counselors, have grit, and it will happen. Culture change doesn't happen overnight. So this is in short for people from Michigan as well as from our illustrious alumni, from our own faculty, to celebrate our accomplishments in quality and patient safety, and thank you very much.